So I am delighted to speak and echo my colleagues with esteemed colleagues. I'd like to thank Niraj, Ricardo, and Eric. Really a beautiful location, incredible speakers and topics. So, and I do realize I stand between you and the bar, so I'm going to move quickly. And I do appreciate being able to speak on one of the multimodal topics to help speed along, which is around lasers and things that I actually reminded me that I opened up several gigabytes of data that Ricardo and I did together. And I'm happy to email you guys. I gave all my slides and info just for time, so sit back, relax, and enjoy. I'm going to zoom through three simple objectives. One is really simplify the physics of how it works and how it measures non-invasively brain oxygenation. Secondly, I'm going to go over some literature, but really give you a case about subarachnoid hemorrhage, which I'm passionate about. And I'm going to go over some pros and cons because it is only one gauge or tool that you have in the neuro-ICU. Yes, I love mathematics and physics, but I'm going to give you really what I think is the basis of near-infrared spectroscopy or NIRS. So in the upper left, this is Franz Jobsis. He was a Duke scientist. He published in the journal Science using cat experiments. We've all done this before where we shine a light under our head and we see photons, right, permeate tissues. It's actually a brilliant idea because you can measure the optical density units, OD units, and their spectral pattern through tissues is how you measure what we call chromophores. And these are light absorbing molecules in the human body. And the two most common chromophores that absorb the most NIRS light are hemoglobin and cytochrome A3, which is the electron transport chain. So brilliant scientist shown there. And you can see in the bottom left the differences in the NIRS absorption spectra. The way you calculate the difference in optical density units is known as the Lambert Beer Law. It's a perfect segue, right, to the beer that's going to follow this session. Now, to go over some important equations, you don't need to memorize these now, but these will be in your handout. Dr. Meyer went over CPP, and from Ohm's law, you can derive cerebral blood flow. You can also do some algebraic manipulation to derive what's called the metabolic consumption rate of oxygen, or CMRO2, and this is equal to the cerebral blood flow times the AVO2 difference. And I'll show you a reference how that can be measured through NIRS. So back when Ricardo and I started measuring this in stroke patients, the hypothesis was, could we use non-invasive NIRS as a surrogate for cerebral blood flow? So they're different units. That's important to remember. They're fundamentally different things to measure, but one could be a surrogate of the next. And the bottom one is really the delivery or carrying capacity of oxygen, the CaO2. And so the hemoglobin component in your blood is the biggest oxygen delivery mechanism. On the far right of that equation, the 0.003 is kind of a fudge factor based on the PO2, but your hemoglobin is a huge driver of the delivery. This is just to show you Tischauer's reference for that equation. And this is data, Ricardo, I went back and analyzed from our publication in the journal Neurosurgery. And the black dots represent the human cases of NIRS. And this was a very tedious experiment. What we did is we measured NIRS units right before we stuck them in the CT angioperfusion scanner, and then we delicately applied the NIRS numbers on the back end. They don't really make plastic NIRS catheters yet. And so the hypothesis really was that there are zones of brain oxygen on the y-axis, these mixed arteriovenous units, against the CT perfusion, so CBF. So two different things. On the x-axis, you have blood flow. On the y-axis, you have oxygen. So flow and oxygen. This was the hypothesis. We hypothesized it would be linear. There were some outliers you can see, like in the red dot, that we didn't really understand. We published that paper and we had to sort of defend it. And you can see in the bottom right, what you see is increased cerebral blood flow. And in the bottom, you see penumbra, that's salvageable brain. And this far left is the ischemic. That's a danger zone for the brain. You have 4 minutes, right? And we know that from ischemic modeling. And so this is the interesting part of using NIRS. And in the upper left, this is a dead brain zone, right? So if the brain tissue is dead, it doesn't extract oxygen. So your NERS units are high, your CBF is low. So this was sort of the data. Maybe we'll get back and finally publish that. And this is just the same phenomenon to look at. This is what we don't want our patients to do. On the upper right, you want to have high oxygen and high blood flow. As you slide down towards zero, and there's data that we have from hypoxic piglet models that's been published in the Journal of Cerebral Blood Flow that shows this exact relationship. When you get down towards zero, that brain becomes dead, and then we'll have basically have a low OEF, or oxygen extraction fraction. So this is a dynamic issue depending on the brain state. Either the brain extracts oxygen, CMRO2, or does not, and it's OEF. So how does NIRS work? You have a NIRS light source, usually between 600 and 900 nanometers. The light, the photons travel, you see in those two banana arc paths. On the right, what you see is a short detector and then a long detector. And so when we say that it's spatially resolved detection, what we're meaning is that some of the photons are measuring the scalp tissue, and the deep tissue is the deeper one. So you subtract those to understand what is the underlying brain tissue's optical density units. This was from a patient Ricardo and I had from a few years ago, just showing a commercial NERS unit. So these go on the front of the head, and you can see that's a limitation. In the upper right, you can see on the left, that's the light emitter, the NERS light emitter, and then the two light receptacles. And this just shows you the 600 to 900 nanometer range. Now this is an important normal graphical slide. And so on the x-axis, what you see is these are like medical students, basically with the jugular venous bulb, which is the blue line, the cerebral oximetry in green, and then the red is basically on arterial pulse oximeter. And what you see is in unison, if you make people hypoxic, they all go down together. But it's important to remember that cerebral oximetry is a mixed. It's about 70-30, so about 70% or 65% venous and 30% arterial. You can see the pulse oximeter on the hand is easier to isolate the pure arterial pattern. We can't do that yet with non-invasive cerebral oximetry. And I think NIRS has allowed us to prevent placing jugular venous bulbs. Those are like putting a central line, but you angle them toward the head. But you can see the utility because they're non-invasive. So they just want to, so, you know, that's the basis of this talk, right? We came here to talk about lasers. And the second point we're talking about is really summarizing the literature. And as I mentioned, we're really going to focus on stroke and subarachnoid hemorrhage. There's, if you look in PubMed, there's an explosion of other intraoperative monitoring in these, and even a carotid balloon occlusion test. A number to remember in that, when patients became symptomatic, the NERS values dropped about 20% of baseline. So again, this is a trend monitor. This was just, Stefan talked about neurointensivists love geeky gadgets. This came out years ago when we did this study. This is in the journal Neurosurgical Focus, back when Phil Tosky was Ricardo's fellow, and we had a physicist, Bob Pulley, and others involved. But again, remember, NIRS is not cerebral blood flow. These are the established methods of cerebral blood flow, but we wanted to correlate the two. And so what I wanted to just quickly show you is on the limitations of NIRS. So in the upper left, what you can see is a hemorrhage in the right occipital pole, and there's that purple-blue bad-looking brain. Purple and black don't come back as often in the analogy. And this is not a good candidate for frontal NIRS, right? If you're monitoring the patches up front, you're not going to see that area, so that's a limitation. The next one below that shows a subarachnoid hemorrhage patient, and you can see that there's a little bit of right frontal oligemia. And then the third panel down shows you a lot of pneumocephalus. And so that patient, you're going to be measuring basically atmospheric air that got in there with a craniotomy. So we don't know what to do with that data. And you can see deeper in that second panel from the left, you see this big area of potential DCI or cerebral blood flow has reduced that blue pattern. So you're not going to measure that deep. One other important number to remember is most NIRS light with spatial resolve go down about 2.5 centimeters. That's it. Now you can configure larger arrays, but you would need to probably shave the head. So that's an important practical limitation. So yes, laser beams, right? It's really cool. We're here on a Friday. We're going to move right along. And I wanted to share with you, I think probably the most illustrative utility of near-infrared spectroscopy in a practical case. So we received a 44-year-old man who is from the prison system, whereas one of our nurse practitioners said a friend from a gated community. He at 1 a.m. was yelling out to the guards an episode of incontinence and was left there for 5 hours. Interestingly, the guards really, I guess they thought he was playing possum or what have you. Anyway, he was finally brought, scanned, shown to have a subarachnoid hemorrhage and comatose and had an EVD placed. So he was in handcuffs at the time. By that point, he was GCS 10T, he was intubated, and in handcuffs, he was able to move everything. So that was a good sign. You can see his vital signs were, again, this gets back to what Stefan said about the standard dashboard of panels. Nothing really horrible. He had a little bronchi, maybe he had aspirated. This was the CT scan. You can see that diffuse star-shaped pattern, a little bit more near his right midbrain and his EVD in place. He had a right PCOM that was cold very quickly. The interesting thing is we didn't get a lot of history from the staff. And what I'll show you on the left upper image, he had a huge spleen and liver. And on the far right, that chest x-ray, the humerus has avascular necrosis. And in the bottom left, you can see he has cardiomegaly. So we were like, young guy, African-American, AVN, hepatosplenomegaly. So we kind of pieced this together and figured out he had sickle disease. Then he became progressive. He had hypoxic, desynchronous, ICP, hypotensive on nimodipine. So we gave him some mannitol, lined him up, and now we have to paralyze him. So it gets to the point where Stefan was talking about, things are fine on a sunny day flying a plane. Things are really terrible if you have a comatose or you have to paralyze a patient. The only thing you can do is check their pupils. So we hooked him up to quantitative EEG, and unfortunately his alpha delta ratio, as Jan Clausen and others were quite low. So that's not really good to trend from. And as echo showed, a high RSVP suggesting pulmonary hypertension. So we go through our ICP algorithm from the base up, manage his CPP, osmotherapy. Now he's paralyzed. You're left, you basically lose your neurologic examination. And at this point, the ICP was in control, but we don't have a neuro exam to see if he's going to develop vasospasm and DIND. We then put a PA catheter in him. I put the numbers there. You can see 22/8. So he had a normal and a normal wedge of 6. So he didn't actually have sickle crisis, and that was helpful. And this storm started developing too. So this is post-op day 3. He starts developing mild vasospasm on his right MCA, and he's in full-blown ARDS. We're bronching him daily. And again, we can't unparalyze him. So this brings up the utility of multimodal monitoring. Why should you care? Again, in standard flights, you need a few gauges: height, weight, temperature, blood pressure. That's fine for flying on a regular day, but you have to know what each one of the gauges mean. This is the cockpit of Shuttle Atlantis. And if you don't know, the escape velocity of Earth is 17,000 miles an hour. This re-enters the atmosphere, or did, at Mach 17. So it's extremely hot, and you gotta have lots of gauges, you gotta have precision flying. So the point being is that when you have very sick patients, you need more gauges, but you need to understand what gauges do. So at this point, I said, let's put frontal NIRS patches on them. And these numbers are staggering. The left, to give you an idea, normal NIRS numbers are like 50 to 80. Okay, they depend on optical density units, but that's just a normal number. It's like a catheter. So his left side was 20, his right was 9. It's the lowest ever reported in human history. Interestingly, his right TCD, I'll show you, was 220. So he was in severe vasospasm, and his sickle hemoglobin count was very high. So you have to apply your physics and physiology. This is his TCD showing severe right MCA spasm. Again, we applied the device. And this just shows you diagrammatically how it works, right? You emit the light and measure the photons, gives you these relative units. We talked about this already. And so this is the crux of this and sort of near the end of the talk. Again, you have to go back to the delivery of oxygen, your cardiac output, and your CaO2 capacity. What's the problem with this equation? Hemoglobin. He's got a genetic defect of the oxygen capacity of his own hemoglobin. It sickles. So what did we do? We gave him 1 unit of blood, then talked with hematology, and they said, let's do an exchange transfusion. We gave him 11 units of normal hemoglobin A. We also injected intrathecal nicardipine to treat the vasospasm. And so what you see on the left upper image is this very asymmetric, very low bifrontal NIRS. What you see in the bottom right is these numbers snap into place, symmetry. They're both in around the 60s. We fixed him. And so this patient later woke up, we extubated him. He had some depressed effect. Of course, he was still in chains, and his buddies with Kevlar and Glocks took him back, but he survived. So I would say there's limitations to using lasers in your ICU. Hopefully they're ill-tempered, or you can use the neurologic exam. It is non-invasive. I think can replace the jugular venous bulb. You have to apply supply and demand physiology. You have to think, do they have enough oxygen, oxygenation, cardiac output, and so forth. We've gone over those. There are benefits, but many limitations we reviewed. Also, NIRS should be integrated into your dashboard with other components. And also, like any gauge, you have to be hypothesis driven. So if you're going to put a NIRS gauge on, you have to know the normal values, say between 50 and 70, and then trend them. And I'll stop there.
I overestimate my voice sometimes. So really the question was, why don't we use it to see if we are appropriately treating spasm? Because, we set hemodynamic augmentation goals all the time. We say MAP greater than 100 or cardiac index greater than 4. And we think it magically fixes the problem. Maybe in that patient, you need a MAP greater than 120. And probably having NIRS on those patients, especially if they're comatose and you don't see a reliable, you don't have a reliable exam to go by, will actually tell you if you're hitting a metric that's clinically relevant. Otherwise, it's just an arbitrary number.
That's a great question, Raj. I think the first issue is awareness and adopt, more global adoption. I think a lot of people don't know when to use them or what particular indication. And for me, it's been a learning curve. I think the second question you ask is excellent, because if you plug in NIRS, you can do some Cambridge analysis to determine, are they autoregulated, are they trending towards spasm, and use it in your management. But I don't know. I'm a fan of them. I don't use them on all my patients, but I don't know why other people don't use them more widely.
I mean, the case that you described, you've got, and Jan Klassen has presented on quantitative EEG and alpha delta ratios, and I think Paul Vespa on relative alpha variability. The problem we run into, as you pointed out, is if they start off normal and then they become abnormal, they're very useful. If they start off severely abnormal, the 0.3s, 0.4s, they're garbage. I don't know what to do with them. So saying that they've now normalized based on some intervention you've done is impossible. Whereas perhaps with NIRS, you don't typically start off, as you said, at 20 and 9. You might start off in the 50s, 40s, or maybe even 60s when you put them on. The other thing we've discussed, and we haven't really incorporated a whole lot because we now have NIRS, we have the foresight, is using it for patients with carotid stenosis who are getting an endarterectomy or a stent, hyperperfusion syndrome. One of the reasons we think that hasn't caught on is because so very few patients have hyperperfusion syndrome. Of course, they have a bad outcome if they do, but you see it once, maybe every couple of years, whereas vasospasm we see all the time, and treating for vasospasm we do all the time.
Great point.
It would be very interesting. It would be very easy to slide this on the IR before you open the carotid. And as you said, 110, 140 minutes. It might be that this patient, again, you have a NIRS at baseline of 6, and now you open, now you go to 140. And you could say, you know what, maybe this is too much. And use that to migrate to normal level.
Yeah, there was a Japanese paper that looked at that too, but again, small case series. For some reason, it's never caught on. Maybe it's something we should do as a group and probably study it a little bit more.
So we actually tried to look into this in the people that go for mechanical thrombectomy, where they have a CTA before and angio before, and it was NIRS plus ultrasound, but it didn't correlate at all. So I'm not sure if it's a device problem, if it's something else, but we didn't have any luck with that.